Good afternoon. My name is Dr. Zayd Ahmed and I'm from Ramaya Institute of Medical Sciences. So basically my topic for today was electrical storm. So in patients with structural heart disease, they develop recurrent ventricular tachycardia. For this to happen, you need basically a substrate, that is the ischemic DCM or a non-ischemic DCM, and then we need to have a trigger in terms of some infection, inflammation, or any electrolyte disturbance that can trigger this VT storm. So because of this, there's overt sympathetic activation. This leads to further VT, and it's a vicious cycle which keeps on happening. So the patients who present to us in VT storms usually have an ICD in place. So coming to the management of VT storm, the first thing we need to do is to interrogate the VT, to interrogate the ICD. So we have to see whether it's actually VT or it's an atrial fibrillation with fast ventricular rate, or some kind of disturbance happening that has led to the ICD interpreting and shocking. So we have to interpret that first, following which we have to switch off the therapy. The first line of management is antiarrhythmic drugs. We have to start the patient on IV amiodarone. We have to start the patient on lidocaine if it's ischemic ventricular tachycardia. The second thing, we have to start the patient on beta blockers, let it be IV esmolol, or non-selective beta blockers such as propranolol have shown to be more beneficial than selective beta blockers in case of an VT storm. The third thing, because of the recurrent shocks and ventricular tachycardia, there's increased sympathetic activation. So because of that, we need some kind of sedation. We have to start the patients on IV diazepam, lorazepam, or dexmedetomidine. And if the patient is still continuing to having VT, what we have to do is we have to intubate the patient, and we have to put the patient on general anesthesia. IV propofol is preferred. So we are managing all this. At the same time, the VT can be hemodynamically stable or unstable. If it is unstable, it will further lead to hemodynamic compromise. We have to put the patients on VATS, let it be an IABP, which is easily available. So we maintain the hemodynamics of the patient. The second step after this, if it's still despite the antiarrhythmic therapy, if the VT is continuous, then what we have to do is the first line of therapy is doing an electrophysiological study, and then finding out where the VT is and then ablating it. That is class 1A indication. Then if in some cases where there's mid myocardial scar where and the anatomy is difficult, you cannot ablate the VT, you have what I was concentrating on my seminar was something called as stellate ganglion block. It is an easy procedure which can be done ultrasound under ultrasound guidance. We have to basically locate the stellate ganglion behind the carotid artery and in the plane of longus colli muscle. We have to infiltrate, let it be bupivacaine, or else we can infiltrate alcohol, which will reduce the sympathetic activity, and it will lead to reduction in VT episodes. So then further, what long term, what we have to consider is we have seen good results with stellate ganglion block, almost 92% reduction in ventricular arrhythmias, repeated VT attacks with these therapy. The final thing which we have to see is long-term management of these patients. We have to continue the patient on oral amiodarone, beta blockers, and then we have to continue this patient on oral mexiletine and follow them up. In case if the VATs are still on in long term, we have to definitely consider heart transplant for these patients. It is something which we as cardiologists and cardiac centers which we deal with regularly. We need to be we need to know this in detail on how to manage a case of VT storm. So that was my case presentation. Thank you.